In the UK and in several countries around the world, patients who are getting treated with chemoradiotherapy were getting neck dissections, removal of the lymph glands in the neck routinely. So everybody who was getting a chemoradiotherapy and had big lymph glands in the neck would get an operation. Obviously the operation carries the potential risk for complications, effect on quality of life, toxicity effects, and we wanted to see whether we could spare patients that toxicity and those complications, and that was the main driver. There was a second driver, and that was we were trying to see whether we could reduce costs, improve cost effectiveness of the treatment, and that was a kind of secondary look or driver for the study base. So, as you know, the PET-CT scan is a functional imaging study. It means that it not only looks at the changes in the anatomy of the patient, but also looks at the function of the tumor and its glucose metabolism. And so we use that PET-CT technology to see whether patients who've had chemoradiotherapy still have active disease after the treatment. And so in the context of this study, what we did was patients got chemoradiotherapy, and then after 3 months they got a PET-CT scan, just one PET-CT scan. And if it was negative, then we thought that they would have a very high chance, over 95% chance of being clear of disease. If it was positive or equivocal, then they went on to have the neck dissection. And as the study is done by a PET-CT scan radiologist, a nuclear medicine radiologist, and is read by the radiologist and then reported just like any normal imaging is done, basically. And that's a big change to what was happening in the past, as I mentioned, where every patient was having a neck dissection either up front or after the chemoradiotherapy. Well, what we found was that the PET-CT scan surveillance arm was exactly the same in terms of survival as the neck dissection arm. There was no difference between the two. So it was non-inferior, as we say in technical terms. But it also meant that only 20% of the patients needed the neck dissection instead of the 100% that were having it previously. They had far less complications, they had far less serious adverse events, and their quality of life was essentially similar. And on top of all that, the PET-CT scan guided surveillance arm was more cost effective than the previous planned neck dissection arm. So our recommendation now to clinicians is that the PET-CT guided surveillance arm should be the standard of care for these patients who have big nodal disease, getting chemoradiotherapy, and that's how they should be managed in future, basically.